I'm Sejal Saglani. I work at the Brompton and Imperial. And oh wow, we've got consultants. I didn't expect that. Well, thank you. I'll just give it literally another couple of minutes just so that as many people as possible can join, and then we'll start. And if you don't mind, as Nicola had said in her email, if you could mute yourselves and your video, then I think that it improves the quality of the call. So I'm just going to give it 1 or 2 more minutes and then we'll kick off. Thanks very much. A start and people can join whenever they can, which is great. So thanks all for joining and thanks to Nicola for organizing this and Andy. So I'm going to try and give you a feel for how the important points about the diagnosis and management of preschool wheeze, and hopefully give you a bit of an update on how we're trying to manage these patients at the moment. And there is some interaction as well. So Nicola set up a poll and there'll be some questions that come up. So please do answer them on the poll. And then between us, we're going to work out how to give you the feedback from that. But yeah, so please have a go. I can't see what you answer. So, hey, that's great. The outline of the talk is I'm just talking about, this is quite important actually, talking about children aged between 1 and 5 years. So when I talk about preschool wheeze, that doesn't include children who have got bronchiolitis. So it's not kind of the management of the acute presentation of wheezy infants or, who present with bronchiolitis. It's very much about recurrent wheezing beyond the age of 1 and what we do about the diagnosis and management of that. So we'll focus initially on diagnosis. And the third bullet point here is quite important, and I think that's probably part of the most important part of this talk, is kind of the alarm bells, red flags that should come into your mind when you're seeing a wheezer that's coming in again and again and again. And it's like, when we've got older children with asthma, there are certain alarm bells we have thinking, why is this child needing so much treatment? I'm on this amount of treatment, which means it's severe, so I should be referring on. I don't think we're as good as that for preschoolers, and I think it's quite nice to have some guidelines in your head about, now, hold on, this kid's been in 5 times into HDU in the last 3 months, those types of things that should be making you think, is this straightforward wheezing or is it something else? We will talk a little bit about the management of acute episodes, and then the last part will be about sort of maintenance therapy to prevent episodes and how we're trying to use objective biomarkers in these patients more and more to try and decide how to treat them. So the first question, this isn't the question for you, this is just the general question that we should be asking ourselves when we see these patients. Now, for me at the Brompton, we don't have a casualty, so I often don't see these kids when they're acutely unwell or wheezy. So the most important part for me is when I first see a child is actually establishing whether the child in front of me does have wheezing or not. And that sounds simple, but it's not often as straightforward as that. So when I'm seeing patients in the clinic, the sort of most important thing is to ask open-ended questions and use terms like, does your child have noisy breathing? Rather than sort of saying to the parents, does your child wheeze? Because if you say that, they'll probably say yes to keep you happy. So open-ended questions, asking where the noise is coming from. And what I might mean by this is really simple, just asking, I hope you can see me pointing to my neck. Is it coming from up here or down on the chest? Point to the chest. And there is some research to show actually parents are quite good at saying up here or down there, and that puts you in the right direction. If they're pointing up here, then at least it's probably not wheeze and you know something else. If the parents are feeling brave, you could ask them to mimic the noise, but that's a bit harsh to expect them to do that. The best thing is doctor diagnosed, doctor confirmed wheeze. So listening when the child is acutely symptomatic, really, really helpful. Looking for all the cues, you know, recession, respiratory distress, and obviously the stethoscope is sometimes useful as well. In this day and age, I would really, really recommend this. Tell the parents, use a smartphone and record the noise and record the child. That's really, really helpful if you're in any doubt about what is this wheeze or isn't it? And what we do at the Brompton, for our research mainly, to really confirm a diagnosis of wheeze, is we use a symptoms video. So we show the parents some clips and we ask them, do any of these noises or sounds or anything that you're seeing resemble what your child is like when they're unwell? And so this is where you come in. So I'm going to show you the 4 clips that we use at the Brompton, and followed by each clip, I'm going to ask you what you think that noise is. So I have to come out of my presentation here, I'm sorry, but I will show you the video. So here's the first one. Oh God. Right. Okay, so that's the first video, and this is the question. What do you think that sound is? Number 1, if you think it's wheeze, press no. Oh, perfect. Thank you, Nicola. Okay, is it wheeze? Is it an upper respiratory noise? Is it stridor, or is it a rattle? So I think what I don't know is what you have to do to make it work. Nicola, is it obvious what everyone has to do to answer the question?
Yes, you should just be able to click on it.
Oh, perfect.
Right.
Okay, great. Okay.
We've got 4 answers out of 35 participants so far.
Okay, so I'll give you 5 more seconds to answer that, and then we'll move on. Great. And then you'll show us the results at the end, Nicola?
I can show you them straight away, yeah.
Straight away, perfect. Okay. Okay, so 5 more seconds. 5, 4, 3, 2, 1. Okay, let's see what we've got then. See if this works.
There you go.
Okay, so these are the results. Just over half of you thinking it was wheeze, a quarter of you thinking it was an upper respiratory noise, and about a fifth thinking it was stridor. So that's interesting. So bear that in mind, and we're going to move on to the next video. Okay.
Let me close that down. There you go.
Okay, thanks. So I'll just show you the next video. All right, so same question again, actually. For the poll, what sound do you think that was? Do you think that one was wheeze, an upper respiratory noise, stridor, or a rattle? I'll give you all 10 seconds because that's all you're getting. Okay, have we got some answers then, Nicola?
There you
Great.
go.
So just over half of, perfect, thanks very much. Just over half thinking that was an upper respiratory noise, a quarter thinking that's stridor, and about 16% thinking rattle. That's great, thanks very much. Andy's just said it's hard to hear the noises. Is that true for everyone? I don't know what else I can do to improve that. Nicola, have you got any suggestions? I don't know what to do.
No, I think the only thing is your volume up the highest it can be.
Okay. Was it better when I increased the volume on my video, on my computer? Did that make any difference? No?
I could hear that one.
Okay, let's play that one again and
Okay.
see if that one's better then. Great. Okay, so that one was much better according to Andy. So I hope people heard that one. If necessary, I can go back to the first one again. But the same questions again. For this one, what do you think this noise is? Okay, should we look at the answers? Okay, all right. So a bit of a mixed opinion there. Fine. We've got two more, and then I'll tell you what I think they are. And very happy for you to put questions and say I'm wrong or whatever. Okay. Okay, Nicola, if we could have the questions again.
Yeah.
Okay, and the results? Okay, that's great. Good, excellent. Okay, and we've got a last one, which is quite a nice one. You like it. Okay, and the question. Okay, and the results? Okay, all right. So I'm glad we did that because it just shows, I think, how much, how difficult it can be to confirm the noises. I'll just quickly go through them. I appreciate, sorry, the first couple you couldn't hear very well. This is what we think is an example of wheezing, actually. The child, I agree, had both inspiratory and expiratory noises, and sometimes we think wheeze should only be expiratory perhaps, but this was quite a severe example. And this is our example of a child with wheezing, and there was a dry, tight cough, and often the parents recognize that going together with the wheeze. This was just an upper respiratory noise. I mean, it could be a rattle, it could be anything, but yes, that was an upper respiratory noise, and I think more than half of you thought that, which is great. This was also just a mouth breathing, upper respiratory, don't know what it is, but it's definitely not significant lower airway abnormality. This was stridor, so excellent, well done everybody. More than 80% of you thought this was stridor, and this I think is a really clear example of stridor, so that's what that was, and this was wheezing. Some of you thought this was upper respiratory, and I can understand that because there was a wheeze there with perhaps some element of rattle, but I think the predominant noise here was a kind of a lower airway wheezing noise. So that's where that's what they were. I hope that was helpful for you to just have a feel for how tricky it can be, even when we're all seeing the same patients, to work out whether it's wheeze or not. But it's really important to get that bit right, because if you don't get that bit right, the rest of the management won't work. Because if the child hasn't got wheeze and you're treating wheeze, they won't respond to the treatment. So that's really, really important. And then I just wanted to highlight some things that should sort of ring alarm bells. And one of them is that if you take a history and the parents say the noisy breathing has been there from birth, that's not straightforward preschool wheezing. There's something else that needs investigation. You need to think about why. A wet cough, and I'm sure most of you have been taught this again and again and again, but a persistent wet or productive cough is not straightforward wheeze. It needs to be investigated for what the underlying problem is. Is there a chronic suppurative lung disease? Is something else going on? That really has to be investigated and cannot be left. Obviously, failure to thrive is an alarm bell for all of us. And on your examination, the sort of unexpected findings would be an abnormal voice or an abnormal cry. Stridor, it obviously is abnormal. Anything that doesn't feel quite right with a sort of, the child sort of should almost be otherwise completely well, except these episodes of wheezing. And this is the other thing I wanted to highlight, that in my head, I have a cutoff for what's high dose treatment for an older school-age child with asthma, but I think we need a similar cutoff in our head for preschoolers. Now, not all preschoolers will be given maintenance treatment or inhaled steroids. I fully accept that. But if you've got to the stage of prescribing inhaled steroids, and if they're on a dose of 400 micrograms per day or equivalent of budesonide, and they're not responding, something's not right. And you need to be thinking, what else is going on? Does this child need referral? Am I missing something? So I think that's quite an important list of things to have in your head. And then this is another slide that really needs to be in your head every time you see a preschool wheezer. So on the right-hand side, we've got these differential diagnoses that should be going through your mind every time you see a preschool wheezer. Is this reflux? Is there a problem with this child's airways? If it's a wet cough, is it CF? So I think this list sort of needs to be there every time you're seeing, especially a severe preschool wheezer, but any preschool wheezer really. So when they come in acutely, what should you be doing? And really, this is all we've got. It's really depressing. We haven't got huge amounts of treatment for this age group. The main thing is bronchodilators and oxygen therapy. Oxygen is the single most important thing, but also bronchodilators. Which bronchodilators? Well, you can definitely give beta agonists, and you can try anticholinergics. There's no real evidence to say one is better than the other. I would suggest you give a trial. If the child responds, stick with that one. That's what I would do. Usually, I think we would try salbutamol as our first line, and if that's not working enough, then you would add in perhaps ipratropium bromide. But saturations, hypoxia is the key thing. You must look for that and must treat with oxygen. So that's the only kind of hardcore therapy we've got for the acute episode. What about magnesium sulfate in a preschool child with wheeze? Well, I know it's on most of the protocols in most hospitals for acute wheezing episodes. I just wanted to show you this data to highlight that preschoolers don't always behave as standard asthmatics, and that's the whole point of this talk. And this is some data that came out last year, including children aged 6 months to 4 years who all presented acutely with wheeze associated with a viral infection. And despite inhaled salbutamol, as you can see, they weren't much better. So they were randomized to either IV magnesium bolus or saline. Now, the important thing here is these children, if they were already on treatment for asthma type symptoms, they were excluded. So it was very much focusing on what we would call viral wheezers. And the primary outcome was a score, which includes kind of a symptom score and a respiratory distress score. And these were the data. Now you might think, so the black squares here are the children that got the magnesium bolus, and the open circles are the placebo. The thing to note is it just happened by chance, that the randomized children that got magnesium were at a lower score when they started off compared to the ones that got placebo. That was just by chance. But the important thing here is the gradient of the line is identical really for both of them. So actually the sort of viral wheezers didn't respond significantly better to magnesium than placebo. So your response to the sort of traditional intravenous therapies that we use may not be as good or the same in preschoolers as in school-age children. That's all I wanted to highlight with this. And as well as IV magnesium, the other thing that can be tried is actually nebulized magnesium sulfate. So should we be using that in this age group? Now, the only trial that's really been done properly to look at the effect of nebulized magnesium is the magnetic trial published several years ago now. And the reason I'm mentioning it is because it included a wide age range. So from 2 to 16 years, so a really wide age range of children that got either nebulized salbutamol with ipratropium and magnesium, or the magnesium was replaced by placebo. And again, the outcome was like a severity score at 60 minutes. And the reason I'm telling you about this data is because the median age of the children was 4. So actually preschoolers were a significant proportion of the children that were included. Now the primary outcome, yes, it was significantly lower in the group that got nebulized magnesium, but the message from the trial was that this difference of 228 compared to 244 as the score is not clinically meaningful or significant. So overall, the trial was felt to be negative from a clinical perspective. But when they did a sort of a subgroup analysis, there was a group, the ones that had low saturations, i.e. the more severe children who got magnesium seemed to do well. And you kind of maybe nebulized magnesium may work better in children who are sick with acute hypoxia. And this is a sort of a Cochrane review just published in 2018, looking at all the trials that have included nebulized magnesium in children of all ages. And the message was that nebulized magnesium is safe and it may be beneficial, especially in severe exacerbations. And I mentioned this in the context of preschool children because the magnetic trial had a big component of preschoolers, and because sometimes it's so hard to get intravenous access when preschoolers are acutely unwell, they're wheezy, they're sweaty, it's a nightmare. So it could be something that could be thought about as an option in children who are severe enough to be hypoxic and in your emergency department. So I'm just putting this out there for you to think about as an option. This hasn't been tested just in preschoolers or just in hypoxic children in a formal clinical trial. It's just from this Cochrane review and that one large trial. But the sort of most important message here is if the child in front of you is not hypoxic, then please do not use nebulizers. That's the single most important message because a nebulizer and spacer is probably better than a nebulizer in this age group. So please do not use nebulizers in preschoolers, in fact in any child, if they're not hypoxic. You must just use an MDI and spacer, and that's really important. But if you're going to use an MDI or an inhaler and spacer, make sure first of all you use a spacer. Now I've put this up because this child is quite rightly having his inhaler with a spacer, but he's got a mask. And I think this child might be a bit too old for a mask. So the reason this picture is up there is for you to think about when to swap over the spacer with a mask to a spacer with a mouthpiece. And that happens in the preschool arena. So I would say by the age of 4, the majority of children should definitely be using a mouthpiece. But even, 3.5 and upwards, you should be seeing, is this child ready to have a mouthpiece and not the mask? But of course, if they've got the mask, there's no point them drinking the medication. So yes, you must use an MDI and spacer, but what's even more important is that the technique has to be correct. Otherwise, it's not going to work. This is so important. We've got to get the basics right. And often children are not responding simply because we're not doing the basics. Okay, so this is, I hope it's not controversial anymore, but I'm quite interested to know what you think about the role of a short course of oral steroids for an acute wheeze attack? So here's your next question. Would you use a short course of systemic steroids for a preschool child aged between 1 and 5 presenting with an acute attack of wheeze? And your answer is simple, yes or no. Go for it. I'll give you 5 seconds. Okay, Nicola, have we got any answers? Great. Okay, so 2/3 are converted. I'm really pleased about that. I've got 1/3 still to convert. Okay, so I've got the next few slides to try and convince you that maybe you shouldn't be thinking about it too quickly. So I admit that question was a little unfair because I just said any child with wheezing. And of course, there are some scenarios when we might use oral steroids, but for the majority of children, I'm not sure it's indicated. And a lot of that data comes from this systematic review, looking at the efficacy of oral steroids in acute preschool wheeze. These were all the trials that were included in that review. And the bottom line, in terms of the clinical outcomes that matter to us, there was no effect of oral steroids on hospital admissions. As you can see, this forest plot, very easy to interpret, don't need to be a statistician to understand that it's completely across the middle line. And there was no effect on unscheduled healthcare visits either. So for us, the sort of clinical outcomes that really matter, hospitalization, unscheduled healthcare visits, no efficacy of oral steroids in preschool wheezers. And that does not matter even if they are the preschool wheezers who you think might have asthma. So you know the ones that you think have got atopy, the ones that are wheezing with and in between colds, and all of those kind of features that make you think this child may have asthma. In this age group, surprisingly, there is no effect of oral steroids in these children in this age group. We don't know why, $1 million question, but they're really not very effective at all. And considering the fact that these children, as you know, can be coming in once a month, once every 2 weeks into emergency department, and they could be getting 3 days of steroids each time over the period of 6 months, that can significantly add up into a marked steroid burden with marked adverse effects. So if they're not hypoxic, I would not suggest giving oral steroids. I just want to show you this trial because it kind of tried to put a spanner in the works. I used to give this talk really confidently, and then this trial came out and God, yeah. Anyway, so it was looking at oral steroids in preschool children with virus-associated wheeze, prospective randomized double-blind placebo-controlled trial. Hooray, great science. Trial design, great, prednisolone or placebo for 3 days, and the children are in the right age group, right, 2 to 6 years, so that's a good age group. They all had wheezing with a cold, basically, but it was a single center hospital in Australia, and the children were randomized in the emergency department. Their primary outcome was total length of hospital stay, and they'd planned a non-inferiority trial. But what they report is a post hoc analysis, and that's what's slightly upsetting. So for their primary outcome, which was total length of stay, yes, it was lower, definitely lower in the group that got steroids. I have no problem with that. But the group that really, really benefited were the ones that stayed in hospital at least 12 hours. That's important to bear in mind. So it wasn't the children that were just observed in casualty for 4 hours that really benefited. No, it was the ones that needed to stay for at least 12 hours, usually the ones that stayed overnight, had an admission. That's the first thing to say. And the second thing to say is this report, they've actually although they designed a non-inferiority study, they report then a post hoc analysis and say there's a superiority effect. The problem for me is that this is the trial I've just shown you on the left. We've had previous really good trials that have said oral steroids don't work. And one of the really, really strong trials, big trials, was this study published in the New England 10 years ago, which showed no benefit of steroids on length of hospitalization. And the age range was very similar, 10 to 60 months. This trial was designed as a superiority study. That's quite important. The number of patients was really, really similar. And the primary outcome, this trial is negative, this trial reports itself as being positive, but actually, if you look at the difference in length of stay between placebo and prednisolone in each trial, it's exactly the same. It's 170 minutes. So it's just less than 3 hours benefit that you get in a child that comes in with an episode of wheezing. And I think I'm not going to tell you what to do, but I think you need to decide that is this duration worth it? A reduction in just less than 3 hours worth it for a child who could be coming in every 2 weeks and getting 3 days of prednisolone, given the fact that the most benefit is in the ones that have to stay overnight anyway. And by the time you get that prescription from pharmacy, it's going to be well over 3 hours, I can guarantee you. So is it really worth it? And is this data from this latest trial actually telling us there's a benefit of oral steroids? I don't think so. So my message for oral steroids in the context of acute preschool wheeze is that I don't think they should be used if the child is not hypoxic. There's no evidence of benefit in reducing the duration of symptoms, the time to the next attack, or preventing hospitalization. I really don't think there is, and I'm very happy to take questions on this and be, and be told I'm wrong. I think oral steroids should be considered in children with a severe episode. And for me, a severe episode is not just one that needs oxygen, but also where you're heading towards kind of HDU and, long intravenous therapy, that sort of thing. I absolutely agree. For that kind of severe episode, yes, steroids, because we've got nothing else. But for the others, I don't know that we've got enough data to say it works. But please do put questions on the chat and I'm happy to take them. So what about antibiotics? Okay, so the reason antibiotics for an acute attack were ever introduced were because of this cohort data from the Danish group, who showed that when you look during an acute attack on a preschooler and look for the bugs, the organisms that are causing that attack, then just as many attacks were caused by bacteria as by viruses. So people said, well, can we use antibiotics then to treat acute attacks in wheeze because nothing else seems to work? Well, we've had 3 trials now that have looked at the efficacy of a macrolide antibiotic, azithromycin, short-term course of azithromycin for a preschool wheeze attack. And this is a summary of the data. And overall, actually, if you look at effect on time to next exacerbation, if you look at duration of symptoms, if you look at hospitalization, there isn't really any convincing evidence that azithromycin is better than placebo for an acute wheeze attack, okay? This is the data from just one of those trials, which I think is a really nice pragmatic trial. And the reason it's published in PLOS One is because it's negative, I think. The other 2, yeah, anyway, we won't go there. So this was a randomized double-blind trial, included children aged 1 to 5 years, presented to the casualty with acute wheeze. And at presentation, they were randomized to either azithromycin or placebo. And the primary outcome was time to resolution of symptoms. And there's the data. Again, you don't need to be a statistician to see that there is no difference between azithromycin and placebo. So at the moment, I would not suggest that you should be putting children who present to the emergency department with an acute attack of wheeze in the preschool age group on azithromycin. We just don't have evidence for it. And I think all you might do is generate unnecessary antibacterial resistance. So that's where we are with that. So I've got a bit of a case to see whether I've converted the 1/3 that wanted to give steroids. Let's see. So it's a 2-year-old boy who has a cold and difficulty in breathing. He presents to the emergency department. It's his first episode. He's no history of atopy. You've not tested, but no history. Normal saturations. You can hear the wheezing. You don't need a stethoscope. And that's his respiratory rate. Okay. What would you do? Give him some oral steroids, give him some azithromycin, give him a short-acting bronchodilator with an MDI spacer, all of the above or none of the above. So Nicola, if you could help, thanks very much. Okay, I hope that's long enough. Shall we look at the answers? Yay! You can have a gold star. even none of the above is fine. I mean, if you think that wheeze isn't bad and he's not in too much distress, I'm very happy to go with that option. So yeah, good. You can all come again to the next talk. Okay, great. So then he gets a bit worse, okay? So he was doing really well, responded really well to the bronchodilator and the MDI and spacer, which you taught him to use perfectly. But then he got a bit worse when he got home, and he came back 12 hours later because despite having 10 puffs of his bronchodilator just 2 hours ago, he was still wheezy. So now his respiratory rate's 45, so that's a 92 in air, and he's wheezing. What would you do next? Nicola, is the poll all in one for this, or?
Yes, so this next one has 3 questions on one page.
Okay, great. So I'll just go through all the questions and then you can answer them. So the first part of the question is, would you give him oral steroids or azithromycin, or just continue with the bronchodilators? And this is the thing I really want to know is, with these preschoolers, what do you do at discharge? Do you tell them they need a review in 48 hours? Do you give them an outpatient follow-up? This was the first presentation, remember? Or would you do both? And would you, in this child, start some maintenance treatment with inhaled corticosteroids? Because then that will lead us on to what we do about preventing episodes. So if you could answer those questions in the next poll, and I'll give you a bit longer to answer. So you might have to do a combined response, Tagore, because you've got lots of people in your room. This is where the fights start, you see, because you won't agree, will you? Okay, does that feel like long enough to answer those questions? Should we have a look at the answers, Nicola? Okay, so the first question, so 20% want to now give oral steroids. So this is where I get a bit frustrated because I can't ask you why. I want to know who answered that they want to give oral steroids and why. I'm assuming it might be because you felt that he's come back, so I need to do something. You might think it's because his SATs were 92%, but actually SATs of 92% in air, I don't think are that bad. He's not yet needing oxygen. I personally would still not want to give him oral steroids. I'd probably want to monitor him and obviously see which direction he goes in, but I don't think he's bad enough yet to need oral steroids. That's my take on that. I definitely agree we should be continuing with bronchodilators as needed. That's absolutely correct. We'll probably have to watch him a bit longer and see which direction he goes in. If his hypoxia gets worse, then maybe we'll consider some steroids, okay? I'm glad that you do arrange for a discharge in 48 hours. I think that's really great. I'm not sure how well that's done nationally, because I know in older children it's done quite well. I'm not sure how well it's done in preschoolers and whether people actually go back to be seen or come back to be seen. But I think that's really important, and I definitely think we should be doing that. Now, in terms of the follow-up appointment for this child, it was his first episode. And it's not yet severe. Obviously, I haven't gone through to the end of the illness, but at the moment, it doesn't feel that severe. So I think I'd be happy to say you don't necessarily have to come back to the clinic, but I certainly think a 48-hour review is really, really important. And 10% would start maintenance therapy. So that's interesting. And we'll go through now who we might consider for maintenance therapy. And hopefully I'll give you a little bit of science behind the thinking. So what I wanted to tell you is Andy and I have tried to summarize this horrible topic in one slide, and I'll go through it with you. It's in allergy in this year. And so the first part of it is what you should do with a 1 to 5-year-old that presents to you with preschool wheezing. And it's everything that we talked about at the beginning is take a history, make sure it's wheeze, make sure it's nothing else. And if it is something else, treat the underlying lung disease. So that's the first part of that algorithm. And for the acute attack, what we've said is assess for hypoxia. And I do think that that's probably the single most important thing for these children is just giving them oxygen if they need it and looking for hypoxia. And then we've said give bronchodilators. a beta agonist and or ipratropium bromide. And only if they're hypoxic should it be nebulized. Otherwise, so exactly what we've discussed. If they get worse, then you may need to consider steroids. You may need to consider a macrolide. I don't think you necessarily should be thinking about it straight away, but if they get bad, you may. And then, as we've discussed, you may need to consider some additional bronchodilators like inhaled or intravenous magnesium. If the child gets better, then just carry on with the bronchodilator, because that's really the only thing that works until the wheeze improves. So that's what we said about the acute attack. So I just wanted to highlight that algorithm to you. But that now it's kind of this million-dollar question of who should get maintenance therapy. And this is a really, really tricky question. And I'm hoping I might be able to shed some light on this. So at the moment, what we're told is if you've got a child who only wheezes with colds, you should not give maintenance inhaled steroids. And if you've got a child who wheezes in episodes, but also has symptoms in between, even without a cold, then they should get maintenance steroids. That's kind of our overall teaching at the moment. And it comes from this European Respiratory Society task force. The problem is, though, this guideline is based on very little evidence. It really, when it was made, we had very little evidence. It doesn't look at the inflammation in the airways. It doesn't think about infection in the airways. It really relies on accurate parental reports, which is really tricky to get the parents to say, does your child only wheeze a cold? Do they ever wheeze in between? You know, it's really hard to be able to do that. And the bottom line is that even if one day a child is a viral wheezer, the next day they may not be. They may be a multiple trigger wheezer, and the symptom pattern can change all the time. And the latest ERS task force, which was still a long time ago now, says even if it's just a viral wheezer, if they're having very severe or very frequent episodes, you can still try maintenance inhaled steroids. So it's really confusing and, you know, not helpful. So what should you be doing? Well, I just wanted to show you some data that we collected quite some time ago from children that come to the Brompton with acute wheezing. And these were children who were in the preschool age group. Yes, they were quite severe. They'd had a lot of hospital admissions and they were on a lot of treatment. So I get that. These are the severe end of the spectrum. But these are the only children in whom we've been able to look in the airways to see what's going on. You can see they were on a high dose of inhaled steroids, and that's the cutoff I asked you to have in your head about something's not quite right. And when we looked at these children, what we found was about half of them, even when they were well, had evidence of bacterial infection in their airways. So this is quite important, that half of preschool wheezers, especially the ones who have more severe wheeze, do have evidence of infection in their airways. And it's not just virus, it's bacteria. And that's even more likely the younger they are. I guess that's the point of this slide. So the younger the children, the more likely they are to have that bacterial infection. Why is that important? Well, why do we use inhaled steroids? The reason we use inhaled steroids is to treat eosinophilic inflammation. So what is the point of giving a child inhaled steroids if they haven't got eosinophilic inflammation, and if actually what they've got is neutrophils associated with infection? So maybe some of these kids don't respond to our treatment because we're giving the wrong treatment, because we're not treating what's going on in their airways. So when we look in the airways of children, yes, admittedly, they're severe wheezers. What do we see in terms of inflammation? Well, whether they're viral wheezers or whether they're multiple trigger wheezers, there's no difference in the number of eosinophils in their airways. We can't use these clinical distinctions to say you'll respond definitely to steroids and you won't, because that's not true. Some episodic wheezers have eosinophils in their airways, and some multiple trigger wheezers do, and some have nothing. And there's no difference in the neutrophils in their airways either. So that's really, really difficult to say who should get. Just using that clinical phenotype does not help us to decide who should get inhaled steroids. But what can be helpful is looking at atopy. So if you take all wheezers together and look at their atopic status, the atopic wheezers are much more likely to have eosinophils in their airways. Yes, there's overlap. Fully accept there's an overlap. But at least you can try and find a group that are more likely to respond to inhaled steroids. So now we've got a test. Look for atopy, do some skin prick tests, do a specific IgE, work out who is atopic, and maybe that's the child that will respond to inhaled steroids. And the other reason that's quite nice is because if you look at bowel eosinophils, it correlates quite well in this age group to blood eosinophils. So we've got another test. Do a blood test to look for eosinophils when they're well, and maybe then you'll find the children who've got eosinophils in their airways who might respond to inhaled steroids. So we're trying to adopt an objective approach to decide which preschool child should get inhaled steroids and which shouldn't. And this trial was really nice at helping us to work that out. It essentially tried to identify differential responders to inhaled steroids. This red line are the children that respond best to inhaled steroids for maintenance therapy. And who are they? They are the ones who are atopic to aeroallergens, and they are the ones who have a high blood eosinophil count when they are well. Both of these tests are done in the clinic when they are well. If they are positive, then that child is very likely to respond to inhaled steroids, and then you should start them. And that's kind of what we're trying to do more and more with these patients. This is some data. It was a cluster analysis of children, again, who are bad enough to need a bronchoalveolar lavage, and showed two main preschool clusters. The first one here are the ones who've got severe wheeze and they're sensitized. So they're probably steroid responsive, the group I've just talked about. But there's also this group here. They were neutrophilic and refractory to steroids. So who are they? How do we find those, and what do they mean? Well, remember I said at the Brompton, we find quite a lot of children, about half of them have infection, bacterial infection in their airways. This is some more data from Germany, who showed exactly the same. Severe wheezers that are needing a bronchoscopy, about half of them have bacterial infection in their airways associated with neutrophilia. So maybe these neutrophilic ones don't need steroids, maybe they need something else. If you just put all wheezers together and split them according to positive infection or negative infection by traditional culture, not microbiome, the neutrophils are higher in the ones that have bacterial infection, suggesting the infection is driving the neutrophilia, suggesting in the airways. And when we've looked using the microbiome at these wheezers, and you just do an unbiased analysis, there are two groups. A group that have predominantly Moraxella catarrhalis in their airways, which is associated with neutrophilia, and the abundance of the Moraxella associates with more neutrophilia, again suggesting it's the infection and the amount of infection that drives the neutrophilia. So azithromycin won't work as an anti-neutrophilic agent, but it would work if we're using it perhaps as an antibiotic. But we can't do a BAL in all of these patients. What's a biomarker to use for these children to find the ones with infection? Well, what we do at the Brompton is an induced sputum in these children. We use 3% hypertonic saline, and we get good numbers of samples. That's very, very safe, and we find a good relationship between the sputum and the BAL for infection. Not good for inflammation, but it's good for infection. So what have I just said in this last hour? Well, I hope I've told you that I think there are two things that are driving preschool wheeze in preschoolers. The first is children that have predominantly sort of an allergic eosinophilic picture, and they should be given inhaled steroids to prevent their preschool wheeze attacks and symptoms. But I think there's a second group in whom infection and bacterial infection is driving their symptoms. They're associated with neutrophils, and maybe they should be given targeted antibiotics to prevent the wheeze. We've got good data for this. We've got no data for this. This is just me saying what I think might work. We need interventional studies that do this, take this approach to really work out whether this is the way forward. But maybe it's going to be the way forward for us to kind of finally win with this horrible, horrible age group. So this is the final bit of the algorithm that I was telling you about. So for maintenance therapy, Andy and I have suggested we should look for treatable traits. If a child in front of you has got atopy and or peripheral eosinophilia, give a trial of inhaled corticosteroids. Ensure the device and technique is correct. Don't just carry on forever and ever though. Bring them back. If they've responded, stop the steroids. Because it might be that the natural history is that they're going to get better anyway. But if the symptoms come back and they'd responded, then you should restart the inhaled steroids and give them the lowest dose necessary to maintain control. If they're not atopic and they haven't got a peripheral eosinophilia, just use bronchodilators as needed. That's all you can offer these children. But if they've got evidence or anything that makes you think they might have bacterial infection, investigate and then give targeted antibiotics. And that's it. I've got no idea how we're doing for time. Oh, we've got 10 minutes. So please do type questions on the chat, because that would be great and make it more interesting for me as well.
Thanks, Sejal. There already are some questions on the chat.
Oh God, I can't see them. Okay.
Okay, so the first one from Hermione: is there a role for inhaled steroids during an episode?
An acute episode?
Yeah.
Okay, so yes, there's been one trial that looked at the role of high dose flixitide for an acute wheezing episode. It was published again about 10 years ago now, and it did show some benefit of high dose flixitide, but I would not suggest you use it, because the dose of flixitide used in that trial was 1.5 grams a day. And it was given for up to 10 days. So if you can imagine, Hermione, that during the winter months, these children come in almost every 2 weeks with an episode, it kind of ended up that these kids were on ridiculously high doses of flixitide almost all the time. And one of the biggest adverse effects of that trial was a reduction in growth. So they had significant side effects of that high dose inhaled steroids. So yes, we have evidence that they can work, but at the moment we're not using them very routinely, because we're quite worried about the adverse effects of inhaled steroids when these episodes can be so frequent, and you might need to use that high dose for quite long. Yeah. Is there another question, Andy? Sorry, I can't see the question.
Yes, so there's a question. What about the role of Montelukast? I think it doesn't specify whether acute or in the acute attack or chronically, but perhaps you cover both.
So I took out Montelukast because I don't think it works. So there's been one trial that's looked at the role of Montelukast in the acute episode. That was called the WAIT trial, and it essentially it looked at the role in all children, and if you looked at the primary outcome, there was no benefit of Montelukast in reducing the duration of the episode or symptoms or anything. There were a subgroup that responded to Montelukast acutely, and they had to have a specific ALOX5 genotype. The bottom line is, I don't have a genotype machine in my emergency department. I don't think you would either. So you could perhaps try it in a child. What you could do is take the approach to the family that here's a prescription for Montelukast. Next time your child gets a runny nose, start it. If they get better, perfect. They're that genotype that responds, and they can carry on using it. If they don't respond, do not use it again, with the big caveat that Montelukast can have a quite nasty response, side effect on behavior and nightmares. In terms of using it as a chronic treatment, yes, you can trial it instead of inhaled steroids. There haven't been specific, so the data I showed you about the differential responders to steroids, they didn't really show differential responders to Montelukast, so difficult to know, but previous trials have shown that if you have that kind of phenotype that's atopic, with a family history of asthma and so on, Montelukast may work if given chronically, but my preference is to give inhaled steroids. I might give Montelukast if the parents are really averse to steroids. That would be the time that I would try it, but on balance, inhaled steroids are much more effective, and if you're going to give something and you want the families to give some treatment, I would just go for inhaled steroids.
And indeed, Francine Duchamp quotes a sort of roughly 20% prevalence of behavioural and psychological side effects with Montelukast, so it's not a benign medication.
No, it's not, we used to give it out like Smarties, but I agree.
The next question is from Hermione. What is the role of air pollution in this age group?
So I'm sure there's a role, Hermione, but all the data that we have is so associative that I don't know how to say that this preschool wheeze episode is definitely because we've got a day of high pollution. What I can tell you is, just like in older children, there's a number of factors that contribute to a child having an episode. So of course, smoke exposure is a nightmare, and you must reduce that. That's the one thing you must do. And I didn't say that's very bad of me. You must ask the parents if they're smokers, and if they are, they have to stop. So there's always a kind of a double whammy or a triple whammy hit that ends up in an acute episode. Smoke exposure plus a day of bad pollution plus a cold is not going to be a good combination. But in terms of the mechanisms that drive the lower airways disease in the context of pollution, really we have so little data about that I don't know the answer. And I guess for me, the thing is, what can we do about the pollution? Because we don't know about the mechanisms of what drives those attacks because of pollution, I don't know what the treatment would be or how it would differ, you know, how you change the treatment or the management, and how do we reduce pollution? I guess that's a public health kind of problem, but I'm sure there is an association, and it is usually several factors coming together that result in that sort of final attack and the presentation. Yeah.
And of course, there's data in terms of predisposition that exposure of pregnant women to pollution impacts the fetal airway development.
Yeah, so probably an impact on small lungs and small airways, just like smoke. Exactly. Yeah.
Got another question here, and an audience, do please add some more if you want. I've got a question from Jonathan Penny. Can I ask about your thoughts on a prolonged course of antibiotics in those with recurrent symptoms to reduce colonization with Moraxella?
Yeah, so that's a really good question. Thank you for asking that. The first thing I should say is we would never give a prolonged course of antibiotics without finding the organism. It's really, really important to give targeted antibiotics. We're not just giving blind antibiotics. We either get a sputum sample or a lavage and we give targeted treatment, because there are no trials that have really looked in any other context. There's only one study that's been published that looked at the benefit of a long course of antibiotics, having found a bacteria in the lower airways in severe wheezes. And that's the data from Germany that I very briefly showed. They gave antibiotics in those children for anywhere between 2 up to 12 weeks. It was a clinical observational study, so there was no kind of set period. But they did show that up to a year later, the children that got that long course of antibiotics were better. So I think if they're that phenotype in whom infection is driving the wheeze, then there's a definite role for a prolonged course of antibiotics. At the Brompton, if we find a bacteria such as Moraxella, we would normally give a 4-week course of augmentin and see what happens. And if that really is the main driver, we do see an improvement, but it needs to be done in a formal trial. I fully accept that. Yeah.
So we're getting towards the end, but we've got another really interesting question. What about family history in the absence of a personal history of atopy? How does that influence your decision-making, Sejal?
Okay. I don't allow family history to take precedent over a personal history of atopy most of the time. I feel much more comfortable knowing that the child is sensitized to aeroallergens. The family history has to be the parents, not the third cousin twice removed. That's a complete waste of time. So the only data really that we have that's convincing is that there is an influence of maternal asthma or atopy or paternal asthma or atopy. And in fact, the cohort studies, birth cohort studies that have been done in high-risk cohorts, so the definition of a high-risk cohort would be, for example, if your mum has asthma, that is a definition of a high-risk cohort. They do show that those children tend to be more likely to go on to get asthma. The preschool wheezers tend to be more likely to go on to get asthma. The reason I don't allow in this age group the family history to influence my decision too much is because we have no evidence that any of these treatments stop the child getting asthma. And that's really important to remember. All I've talked about today is managing the illness in the here and now. We have no treatments and we have no interventions that will stop this child in front of you going on to get asthma. And that's the thing it's our biggest challenge and we're trying to get to the bottom of. So if your question for the child in front of you is, I just want to stop this kid coming in every 2 weeks with an acute attack, then you should look at atopy, you should look at blood eosinophils and decide whether they qualify for inhaled steroids. If your question is, I want to stop this kid going on to get asthma like their parent, we've got nothing. And please don't let that influence you. So I don't know if that helps, but I don't completely ignore family history, but I would prefer ideally to see some evidence in the child of atopy if possible. It depends how severe the symptoms are. You've got to take lots of things into account. But the main thing about the family history, especially the parental history, is that it does put the child into perhaps more likely to go on to get asthma. But there's nothing I can do right now to stop that. So I'm not going to just give steroids for the sake of it.
Well, that's really great, Sejal. We're coming to the end of this. Has anybody got any pressing questions for Sejal? If not, I'd like to thank Sejal very, very much for a great talk, great interaction. For Nicola, who's actually made this work,
Yeah.
and for everybody who's turned up and asked questions. Nicola, I think I'm right in saying that this talk will be up online. Do please pass the word around. I'm well aware there are many paediatric trainees who are working their socks off in adult intensive care settings, and please encourage them to download this talk if they have not been able to attend. The next week's talk, I think, is Paul Turner on anaphylaxis. Please also do tell us what you would like as trainees. We've just started off, we've got 6 talks to kick off with, but this is very much, we're feeling our way. Please let us know if you want this to work in another way. But finally, many thanks, Sejal. Big electronic claps for you, and thanks everybody for joining.
Thanks all for joining. Yeah, it makes it much more fun. Thanks.
Nicola, do you have anything? Lots of applause. Nicola, do you have anything you want to add to that?
Thank you.
Just one thing to say, someone's just asked in the chat where the sessions will be uploaded to. I will circulate a link to a shared drive so that people can access them easily through that. So we'll send a link.
And do please pass the link on, guys, to anybody you know who might be interested. This is meant to be freely available, and this is meant to be, hopefully, the way things, even post-COVID, we will continue to have as many meetings as we can electronically, so we can all share each other's expertise without having to schlep across the sector to do it. So many thanks to all concerned. See you next week. We had more than 40 on the call at the top time. Many thanks indeed. Cheers all. Have a good day. Keep safe.